but we are here today to attend one of Revive's next webinars. And I just wanted to say, I want to start by saying a very warm welcome to everyone for joining today. We will start with the usual housekeeping rules. All speakers are on mute, please, and no questions during the presentation, but you may pop them in the chat box and we will attend to them afterwards. The presentation of today will be around 40 minutes, and that will be followed by a 10-minute question and answer session. We are going to start with our usual Revive study update, and today this will be conducted by Prof John Eichelboom from PHRI in Canada, and he's also one of Revive's co-principal investigators. And that will be followed by an introduction to our speaker of today, who is Prof Graeme Meintjes, on the highlights of CROI 2026. A recording of this webinar will be updated to the Revive website after this with Prof's permission, but you can also send us an email, put your email in the chat box, and we can share a copy with you. So over to you, John, to start today's proceedings.
Thanks very much, Elsa, and good afternoon, good morning, everyone. Delighted to give you an update on this very exciting trial, which I think most of you are familiar with. I think it's fair to say that the Revive trial, and I don't see these slides yet, Elsa, but I think it's fair to say that the Revive trial is now the largest ever trial in advanced HIV disease. And Graham, you might correct me on that, but we're heading close to 8,000 patients. I don't see the screen.
Hey, John, Tando is sharing the slides. Is everyone else seeing this?
We're just seeing the front slide.
Okay, so Tando, you can just move to the next slide.
Well, why don't I see it? Well, I don't see the slides, which is a little unfortunate, but I know that one of the first slides is the design of the trial.
John,
Yes.
let me try and share the slides from my side. I just want to see if I can share them.
Okay.
Tando, would you mind just allowing me to share?
And so Revive is an 8,000 patient study that randomizes patients with advanced HIV to receive either azithromycin antibiotic therapy for the first 4 weeks or placebo for 4 weeks. And the main outcome is mortality. And this study is being conducted in 13 countries in sub-Saharan Africa.
Can you see them, John?
I cannot see any slides. Can others see slides?
No, not seeing anything, no.
Okay.
Okay, sorry, let me just try and reshare. I'm so sorry. Let's try and see where the issue is.
And not to worry, because I'm going to present the story and then I'm going to hand over to, oh, it's opening up. Is that you? Me?
Yes, that's me. Let's see, we can see them. You see them now, John?
No, I can't.
No. I think it's just taking time.
But let me carry on because I don't think the slides are essential. And so in terms of the countries, I think we have now 11 of 13 countries activated, and we have 57 of a planned 62 sites activated. And we're still waiting for Cameroon and Kenya, who are late entries into the trial, for them to join. The recruitment has been outstanding, and it's really quite amazing to see this trial roll out. It's in my 30 years in clinical research, this has been one of the most efficiently conducted trials ever. The rates of recruitment, the rates of retention, the quality of the data is really a tribute to an outstanding African network of investigators. And I think when this trial is finished, it'll really be a very large feather in the cap of the network for having pulled it off. As of the 22nd of June, there have been 5,658 patients randomized, and the trial is randomizing at around 250 patients every 30 days. So that's, again, a truly outstanding performance. The graph demonstrating recruitment, we're ahead of target. So as of June of 2026, we're recruiting more rapidly than we had expected, and we're continuing to do so. We've done that now for the past 6 to 9 months. At this rate of recruitment, we may even finish a little bit early, which again is really an outstanding achievement. So with that, we're all, of course, anticipating the results, and we're hoping that azithromycin is going to produce a big benefit. But for that answer, we will have to wait until close to the end of 2027. So with that, thanks very much for your attention, and back over to you, Elsa.
Thank you very much, John. Apologies to yourself and to everyone joining. There must have been a technical issue in sharing, but what we'll do is we will include the update with our recording, and then everyone who wants it can just request that. So moving on to the privilege that I have to introducing our speaker today. Prof Graeme Meintjes is internationally recognized as one of the leading clinician scientists in the field of advanced HIV disease. He's a clinical professor of infectious diseases at Queen Mary, University of London, professor of medicine at the University of Cape Town, and an adult infectious diseases specialist whose research has helped shape our understanding and management of the most important conditions affecting people living with advanced HIV disease. Throughout his career, Prof Meintjes has led and contributed to numerous landmark clinical trials and has played a pivotal role in generating the evidence that informs HIV and TB treatment guidelines globally. He currently serves as chair of the REVIVE Trial Steering Committee, providing scientific leadership and guidance to our REVIVE study as we work towards reducing mortality amongst adults with advanced HIV disease across Africa. Please join me in welcoming Prof Meintjes today.
Thanks very much, Elsa, and welcome everyone. Elsa, I just want to check, are my slides showing?
Not yet, Graeme.
Yes, I can see it.
Okay.
They're also showing on my side.
Okay.
Yeah, I see them now.
Okay, great. Thanks so much, and thanks for everyone for joining. So that the presentation this afternoon is really a report back of some of the selected highlights from the conference on retroviruses and opportunistic infections that was held in Denver, Colorado in February. And this is probably the premier HIV scientific conference held each year worldwide. And I presented an update last year, and this is a similar format to that. It's a massive conference with 3,000 to 4,000 scientists who attend, clinical researchers, basic science researchers, and epidemiology researchers, with over 1,000 abstracts. And so I've really just selected 10 talks. Sorry, can we mute the people who are speaking? Elsa, is it possible to mute people?
To mute everyone.
Just do that.
Elsa, is it possible to mute? Okay, thank you. So just to say that all of the slides that I've going to show you in the talk today have been taken from the CROI website, where the recordings of all the presentations and the posters as well are available. And this is just the link to that if you're interested in viewing the presentations that I'm going to show, or any of the other presentations shown at CROI. So it's all publicly available. And the studies that I intend to cover are listed here. And I'm going to first look at a number of studies related to opportunistic infections and TB, and then look at some studies that were presented related to antiretroviral therapy as well as prevention of HIV. And so the first study I want to look at is a pediatric study that I think was a landmark study for children living with HIV. And this was called the Empirical trial, and was conducted with funding from the EDCTP, and really looked at the issue of children under the age of 1 year old, so infants presenting with severe pneumonia, and whether an enhanced treatment package would improve outcomes for these patients. It was a randomized controlled trial. And this was just a background slide that they showed. It's showing data from a post-mortem study that was done almost over 20 years ago, looking at children who died from pneumonia in the first year of life. And you can see that the common causes highlighted in red were pneumocystis pneumonia, acute bacterial pneumonia, but also importantly, CMV was found in a high proportion of children dying of pneumonia. And that was part of the rationale for this study. Also important to highlight that among the pediatric population, among infants, mortality is highest in the first year of life, and pneumonia is the leading cause of that mortality. So what this trial involved was they recruited infants between the age of 28 days and 1 year who were living with HIV and were admitted to hospital with severe pneumonia. And they were randomized to receive standard of care. And standard of care involved antibiotics to cover bacterial causes, either ampicillin and gentamicin or ceftriaxone. And cotrimoxazole to treat PCP was also part of standard of care in this patient population. So they received standard of care, and then with valganciclovir to cover CMV, and valganciclovir was for 2 weeks, or with the addition of TB treatment as well, or both of those interventions. So there were ultimately 4 arms: standard of care plus valganciclovir, standard of care plus TB treatment, and standard of care plus the 2 interventions. And they enrolled 558 infants across 6 African countries at 7 sites and 19 hospitals. And their primary endpoint was mortality at 1 year, with a number of important secondary outcomes, including safety. And this just reflects the baseline characteristics. So most of the recruitment was in Mozambique and Uganda. These children were extremely ill on admission, with 85% requiring some respiratory support, including 28% needing CPAP or mechanical ventilation. Median age was 4 months, and 60% of them had an oxygen saturation of less than 90%. Severe malnutrition was present in a quarter. And interestingly, I found this fascinating that of the children enrolled, 85% had evidence of CMV in the blood, and that's in the first year of life. And in 50% of them, the CMV viral load was above 4 log, which is compatible with end organ disease, and therefore the pneumonia could be attributable to the CMV infection. So, again, confirming that CMV is a major contributor to pneumonia in this patient population. And what they presented at CROI this year was the CMV results rather than the TB results. Just important to emphasize that. So in the first year of life, essentially, or in 1 year of life, follow up, 45% of participants died during the study, and half of them, just over half of them, during the initial admission. And the headline finding was that those participants who received valganciclovir as part of the treatment of severe pneumonia, in addition to standard of care, had a 21% reduction in the hazards of death at 1 year. And in actual fact, if one looked early at 2 weeks, at the 2-week time point, it was a 40% reduction in the hazards of mortality. So a really important finding for children with HIV presenting to hospital with severe pneumonia in the first year of life, that empirically adding valganciclovir substantially reduced mortality. But I think, the investigators highlighted that infants with HIV who present to hospital are often severely ill with a very high mortality rate, as was reflected by the study of 50% mortality after 1 year follow-up. And the mortality during hospital admission was substantial, but also substantial post-discharge mortality, but highlighting that valganciclovir reduced mortality by 21% at 1 year. So that where it can now be accessed, valganciclovir should be part of the treatment of severe pneumonia in infants with HIV presenting to hospital. The TB data was not presented at this meeting. So to move on to the next study that I want to present, this was a study looking at adults with HIV admitted to hospital with low CD4 counts and started on TB treatment. And this study was presented by colleagues from France. Xavier Blanc presented it. It was funded by the ANRS and EDCTP. And essentially the background to it was that we know that mortality rates are substantial among patients with HIV-TB, adults with HIV-TB admitted to hospital, despite starting TB treatment. And their question was, would intensification of the initial phase of TB treatment improve outcomes? And their intensification involved increasing the doses of rifampicin and INH and adding steroids. And they hypothesized that this would decrease mortality in severely immunosuppressed patients admitted to hospital with HIV and TB. So their primary endpoint was time to death of any cause at 48 weeks after randomization. They had a number of secondary objectives, including looking at safety and iris and TB treatment success. But the patients that they enrolled, to emphasize, were adults with HIV, admitted to hospital with a diagnosis of TB and a CD4 count of less than 100. And this just shows the design. It was a phase 3 multi-center study, 2 arms, and it involved recruitment in 6 countries, Cambodia, and 5 countries in Africa. And they essentially compared, on the right-hand side, standard TB treatment with rifampicin, INH, BZA, and ethambutol to TB treatment with an intensified regimen during the first 8 weeks, which involved a triple dose of the rifampicin, double dose of the INH, and adding steroids for the first 6 weeks. And after 2 weeks, if patients weren't on antiretroviral therapy, they started the antiretroviral therapy in both arms. And I've already emphasized that the eligibility criteria, so HIV infection with a CD4 count of less than 100, and TB diagnosed during that hospital admission. So TB could be diagnosed by a positive expert in a range of specimens, positive urine lamb, or a compatible chest X-ray. And they initially planned to enroll between 1,200 and 1,300 participants, but their study was stopped early by the DSMB for futility after just over 900 patients had been enrolled. And this shows the flowchart through their study, and you can see that roughly 450 participants in each arm in the modified intent to treat analysis. And the baseline characteristics comparing intensified versus standard TB treatment. I just want to highlight there, patients had a low CD4 count. The median was around 40, and many patients had severe wasting, with around almost a third of patients having a BMI of less than 16, and anemia, as we expect in these patients, being common. And this was the headline finding, the primary endpoint, that there was no benefit in terms of mortality at week 48 with the intensified TB treatment. And you can see the Kaplan-Meier curves largely overlapping with a p-value of 0.41. So no difference between the 2 arms, no significant difference. And so no improvement with the intensification of TB treatment, higher doses of TB treatment, or with adding steroids. And when they're stratified by sex and by CD4 count, you can see that, again, the curves are largely overlapping. There is a trend in those with a CD4 count of less than 50 to higher mortality with intensified TB treatment, but that was not statistically significant. So their conclusions were that standard doses of rifampicin and INH resulted in suboptimal concentrations in the blood. I haven't shown that data, but that they did present that increasing the dose resulted in significant increases, as you would expect. But overall, intensified initial TB treatment did not decrease mortality in the severely immunocompromised patients. And they concluded that other strategies are needed to reduce this unacceptable mortality, which, as I showed you in the Kaplan-Meier curves, was over 25% of patients had died by 1 year of follow-up. Alongside the Datura presentation at CROI, Fiona Namale from our research group presented the second part of the findings of the NewStrat TB trial that had been presented. The first part had been presented at CROI 2025. And similar question being asked in the NewStrat TB trial as was being asked in the Datura trial. So background to this trial that we conducted was that, as I've said earlier, mortality among inpatients diagnosed with TB and HIV co-infection in Africa is substantial despite TB treatment. Mortality is between 20 and 35% at 3 months. And then we had previously shown that mortality was associated with higher markers of TB dissemination in blood and urine and an immune profile of innate immune activation and chemotaxis. And we, similar to the Datura investigators, asked whether intensification of TB treatment in our setting with our study with higher doses of rifampicin and addition of levofloxacin could more rapidly reduce bacterial load and improve outcome, and whether adjunctive prednisone for immunomodulation could also improve outcome. But unlike the Datura investigators, we did a 2x2 factorial design. Had a 2x2 factorial design where we had enrolled hospitalized adults with disseminated HIV/TB and randomized them twice to standard or intensified TB treatment and to prednisone or placebo. And intensified TB treatment, as I said, involved increasing the dose of rifampicin to 35 milligrams per kilogram and adding levofloxacin as a fifth TB drug just for the first 2 weeks. And the prednisone was also just for the first 2 weeks at 1.5 milligrams per kilogram per day. And after 2 weeks, all patients received standard TB treatment. We had a pre-specified sample size of 732 and pre-specified that we plan to compare standard to intensified TB treatment and prednisone to placebo. And these are the inclusion criteria. So adults hospitalized with HIV and disseminated TB defined as blood or urine expert ultra positive or urine LAM positive. And the exclusion criteria included rifampicin resistance and another number of blood tests. And we'd previously presented the findings of the standard versus intensified TB treatment at CROI in 2025, which showed no improvement in mortality and an excess of deaths at 2 weeks with intensified TB treatment that led the DSMB to stop that randomization. I'm not going to repeat that here, but what I'm showing you here is the results comparing the prednisone versus the placebo arms. And in this final analysis, which involved the full study population of 732, in the modified intent to treat populations, we had roughly 350 participants in each arm of prednisone and placebo. This is just showing you the baseline characteristics, very similar to the Datura trial in terms of CD4 count. So median CD4 count of around 40. Anemia was common with a median hemoglobin of 8.3. And the majority of patients were urine expert positive, 84 and 83%. So that was the most common test positive in terms of the disseminated TB diagnostic tests. And this is the headline finding from the second part of the trial, which is the comparison between prednisone and placebo. And what you can see is the Kaplan-Meier curves are overlapping. And at the primary endpoint time point of 12 weeks, 17.6% mortality in the prednisone arm, 19.2% in the placebo arm, and no statistically significant difference. So prednisone in our study did not reduce mortality in patients with severe HIV TB. So then I will go, having discussed those studies looking at the treatment of HIV TB. This is a study that I'm going to go on to discuss the prevention of TB in people living with HIV. And this was a study conducted in Thailand called the LTBI study, where they looked at two regimens that are both recommended by the WHO for the prevention of TB in people living with HIV. The one is a 1-month regimen of daily rifapentine plus INH, and the other one is a regimen for 3 months of rifapentine INH given once a week. And these two regimens had not previously gone head-to-head in a large trial. And so they hypothesized that 4 weeks of daily rifapentine and INH, called 1HB, would be non-inferior to the 3 months of weekly rifapentine and INH preventing TB in people with HIV. And they also, as a secondary endpoint, wanted to look at the safety and tolerability of the two regimens. And they pre-specified a sample size of 1,500 participants. So they enrolled Thai adults with HIV, no active TB, on efavirenz or dolutegravir-based ART, and they randomized them to the 1HB or the 3HB. And they could either be receiving efavirenz antiretroviral therapy, or from 2021 onwards, dolutegravir based antiretroviral therapy. And the dolutegravir was dosed at once daily. And we know that the package insert suggests dolutegravir be dosed twice daily with rifapentine, but they reasoned that the people in Thailand have a relatively low BMI, and that would be adequate. And so in terms of the TB outcomes, what you can see is that when they had important to emphasize, they had 3 years of follow-up in the trial and ascertained TB cases. And you can see there were just 2 cases of TB in the 1HB arm and 1 case in the 3HB. So across the 1,500 adults, there were just 3 cases of TB. 1HB was non-inferior to 3HB, and they demonstrated that they was generally well tolerated, with drug-induced liver injury only occurring even including mild liver abnormalities occurring in 7% of participants. They also showed that the strategy of just using daily dolutegravir was sufficient, with over 95% of patients having durable HIV viral load suppression despite being on dolutegravir once daily. So their conclusion was 1HB was non-inferior to 3HB. Both regimens were safe and well tolerated, with low rates of significant adverse events. And the dolutegravir dose adjustment was not required because patients maintained their viral load suppression despite being on once daily dolutegravir. And they argue that the 1HB regimen offers a convenient alternative to 3HB, and are now scaling up the 1HB nationally in Thailand. The next study is also an HIV-TB study, and was presented by Sean Wasserman. Sean, obviously the co-PI of the REVIVE study. This was an ACTG study that looked at the question of the dosing of dolutegravir when used with the Study 31 TB treatment regimen, which is a 4-month regimen that includes high-dose rifapentine and moxifloxacin, and based on Study 31 is recommended as an alternative TB treatment regimen in people with active TB, including people with HIV. And the study enrolled patients who had been diagnosed with TB and were starting TB treatment with the Study 31 regimen of rifapentine, moxifloxacin, and INH and PZA. And the question was, when dolutegravir is given with the rifapentine dosed at 1,200 milligrams, would the dosing of dolutegravir twice daily, so the BD dolutegravir, be sufficient to overcome the potent enzyme induction caused by high-dose rifapentine. We know that rifapentine dosed at 600 milligrams a day with prevention, that the BD dosing of dolutegravir is sufficient to overcome the induction, but is that the case also with the 1,200 milligram dose of rifapentine? And it's an important question to support the implementation of the Study 31 regimen. So what this study involved was that involved recruiting 30 participants at sites in Thailand and South Africa. So PK study, patients with HIV TB started the Study 31 regimen. They then started dolutegravir dosed at BD that continued through their TB treatment and for 2 weeks afterwards, and then they went back to dolutegravir daily together with a 3-drug ART regimen. And PK samplings were taken during the TB treatment while they were on BD dolutegravir, and after TB treatment once they were back on daily dolutegravir. And as I said, 30 participants were enrolled in South Africa and Thailand, median CD4 count 185. And they then looked at the PK comparing in blue when they were just on ART without TB treatment, so daily dolutegravir, to the PK in red when they were on the TB treatment, the rifapentine-based TB treatment, together with BD dolutegravir, and then compared the exposures. And essentially, the ratio of exposure with respect to the Cmin or the trough was reduced 45% with despite the BD dolutegravir with the rifapentine compared to daily dolutegravir, and the area under the curve was reduced 30%. So increased clearance of dolutegravir when dosed with this high-dose rifapentine. But when they looked at what the trough concentrations of the Cmin were in relation to what the target concentrations are, they showed that there's, and I'm not going to go into detail about this, but there are 2 defined targets for dolutegravir trough to provide antiviral efficacy. And in around 99% of participants in a model, or 99% prediction, 99% of patients on the dolutegravir BD with rifapentine were predicted in a model to have exposure above these targets. And in the study itself, all of the patients achieved virological suppression on the BD dolutegravir with rifapentine-based TB treatment. So their conclusions were that dolutegravir clearance was markedly increased by the rifapentine 1,200 milligrams co-administration as part of the Study 31 regimen. But twice daily dolutegravir dosing with this regimen provided therapeutic exposure in all individuals. They were all above the target trough concentrations. There was no safety issues, and all of the participants achieved virological suppression. And the findings support the use of dolutegravir twice daily with 2 NRTIs during rifapentine-based TB treatment. The next set of studies that I want to look at are related to antiretroviral therapy itself. And the first is quite a unique study called the Artistry-1 study that was led by Chloe Orkin. And this was unique in the sense that it aimed to enroll a group of patients that have generally been left behind with the advances in antiretroviral therapy. We know that globally, antiretroviral therapy has moved towards single tablet regimens for the majority of people living with HIV, but people who've been on antiretroviral therapy for years or even decades and have complex multi-drug resistant profiles often still need to be on complex regimens with multiple tablets. And what they asked is if we combine 2 newer tablets into a single daily tablet in these patients, could this provide them with a single daily tablet option? So I just want you to focus on the left-hand side, the blue box. The Artistry population, people enrolled in the study, were people with HIV taking complex multi-tablet regimens, often on these regimens because of complex resistance patterns or intolerance or contraindications or drug-drug interactions. And these patients experience high pill burdens, challenges with adherence as a result. And the complex regimens that they're on are also complicated by the fact that they're often elderly patients with comorbidities on concomitant medications and with drug interactions. And so they evaluated the efficacy and safety of a once daily tablet containing bictegravir, so an integrase inhibitor very similar to dolutegravir, and lenacapavir, which is a capsid inhibitor, which is obviously being rolled out as an injection for prevention of HIV, but can also be formulated as a tablet as treatment of HIV. So it was a single daily tablet of bictegravir plus lenacapavir. And they evaluated whether patients on complex regimens, because of their treatment history, could be switched to the single daily tablet. So the trial involved enrolling patients who were stable, so with a viral load of less than 50, currently on a multi-tablet regimen, and no prior exposure to lenacapavir and no resistance to bictegravir. And they defined a complex tablet, multi-tablet regimen as in the red outlined box, so being on a boosted PI or an NNRTI plus a drug from a third class in addition to the NRTIs, being on multiple tablets, or being on an injectable agent. And they randomized patients to staying on their complex regimen in red, or switching to the bictegravir lenacapavir single tablet regimen. And the primary endpoint was virological suppression at 48 weeks. And just to demonstrate how complex this patient population enrolled in the study was, so it was 557 participants in total. The average age was 60, so a much older population that's usually enrolled in HIV trials. Many of these patients had comorbidities. And if we look at the duration of HIV treatment, these patients had on average been on treatment for 28 years. So that's quite unusual for an antiretroviral therapy trial to be enrolling patients who have such an extensive treatment history. And about 60% of patients were on 3 pills, a regimen that contained 3 pills or more a day. 40% were on twice daily dosing, and many of the patients were on a multi-class regimen. And this just demonstrates that about 2/3 of the participants enrolled were on a boosted PI-based regimen, often with multiple other classes. And this is the headline finding, which is quite a staggering result, that among those patients switched to bictegravir lenacapavir, at 1 year, 96% remained virologically suppressed. And of those who stayed on their same complex regimen, it was 93.5%. So switching to bictegravir lenacapavir was non-inferior to staying on the same regimen. And really, this is it's a small group of patients who've got complex treatment histories, but this is a really breakthrough finding for them, that there's a single tablet regimen option for them going forward. So the conclusions of the trial were the Artistry-1 trial population was older than other registrational trial programs, high prevalence of comorbidities and polypharmacy and prior resistance. But switching to this BIC-LEN single tablet regimen achieved high levels of virological suppression, or maintained high levels of virological suppression, was non-inferior to staying on the complex regimens. There was no emergence of resistance to the bictegravir or lenacapavir. Generally, it was well tolerated with improvements in lipid parameters, as you would expect with patients stopping their protease inhibitors. And so this really, as I said, does provide an important option for this patient population that has often struggled through the HIV epidemic because they started treatment with suboptimal regimens early on and have not really benefited from some of the breakthroughs, but now there's a single tablet regimen for them. And this was just the publication that came out at the same time as the presentation in the Lancet of the Artistry-1 trial. So I next wanted to move on to discussing a trial that was presented from Taiwan. And And this looked at the question of whether patients who were struggling on an oral regimen, antiretroviral regimen, with failure to suppress their viral load because of adherence problems, whether they could switch to an injectable antiretroviral regimen, and this was an injectable regimen of cabotegravir plus rilpivirine. And cabotegravir rilpivirine has a good evidence base, but has largely been studied as a switch strategy in patients who are already suppressed in terms of their viral load being suppressed, and then they switch from oral to cab rilpivirine. But this study asked a different question. They asked if among patients who were on antiretroviral therapy, who were struggling with adherence, had a high viral load, a viral load above 200, could they be switched to cab rilpivirine? And what it involved was the recruitment of 45 participants who were ultimately in the analysis. And they were either kept on their oral regimen for 6 months or switched immediately to cab rilpivirine. And what they showed was that switching to cab rilpivirine significantly improved their ability to reach and maintain virological suppression compared to staying on an oral regimen. So I'll expand it a little bit more. So this was the study design. So it was 45 participants on oral antiretroviral therapy who were not suppressed. And in green, they either stayed in the oral antiretroviral therapy and only switched after week 24, or in orange at the bottom, they switched immediately to cab rilpivirine. And the median viral load was high in these patients at 35,000. What they showed at week 24, so while the first group had been on the cab, it had stayed in the oral antiretroviral therapy, whereas the second group had switched to cab rilpivirine for 6 months at that stage. At week 24, significantly higher proportion of participants in the immediate long-acting injectable group had achieved viral suppression compared to those who stayed on oral therapy. So it was 88% versus 55% viral load less than 200, and 76 versus 40% viral load less than 50. This is just showing it graphically. What you can see, this is over the 6 months when one group in red were still on oral, and in blue, those had switched immediately to cab rilpivirine. So much better viral suppression with the cab rilpivirine. There was an improvement in viral suppression in the patients who remained on oral therapy, but that's probably due to improved adherence support being in a clinical trial. So I want to move on next to discuss a study that was presented, a very large community-based study that was presented from Kenya and Uganda, the SEARCH trial, which looked at strategies for prevention of HIV in communities. And they called this, the intervention that they trialed was a community precision health intervention in rural communities in Kenya and Uganda. And so by way of background, we know that there's strong evidence from clinical trials that PrEP improves. PrEP is highly effective when taken with good adherence, preventing HIV. We know that from observational data that post-exposure prophylaxis is also effective at preventing HIV, but the delivery and uptake remain a challenge. And so this intervention included working with community health workers and a digital health intervention in rural communities to improve uptake and coverage of PrEP and PEP to ultimately reduce HIV incidence. So it was a population-level cluster randomized trial that involved randomizing 16 communities to the intervention or the control arms. And the control arm was obviously standard primary care services in the community, whereas the intervention arm involved the community precision health interventions added to standard of care. And the outcomes were, which was HIV incidence, was evaluated after 2 years. So the intervention involved essentially nesting the intervention within existing primary care services. So at a community level, they worked with community health workers that had been trained by the Ministry of Health but they trained them and capacitated them to provide HIV screening in households and to allow them to refer people that they saw in the households for HIV treatment or HIV prevention services. They worked with the healthcare clinics to improve the package of care for both prevention and treatment of HIV. And they linked the clinic and the community-based services with a digital platform that allowed them to improve follow-up of participants who hadn't, for instance, hadn't attended the clinic visit for the community health workers to assist in the community. And so this just summarizes what this community precision health package involved. In the community, if you just look at the right-hand blue boxes, this involved HIV testing by the community health workers, and then prevention and treatment referrals, and then allowed them to follow up participants who were lost to the clinic. In the clinic, it involved these packages to support adherence to prevention and treatment packages, existing prevention and treatment services. And there was a digital platform, a smartphone app that connected the community health workers in the clinic to allow referral and follow-up of participants. And the primary outcome was HIV incidence assessed using a recency assay, which is essentially an antibody test that is able to detect recent and new HIV infections. And so the communities were randomized to standard of care or the community precision health intervention, and HIV incidence was measured at 2 years in the community with a number of secondary outcomes. And so they're randomized, as I said, 8 communities to control, 8 communities to the intervention. And at 2 years, they performed the recency assay in roughly 40,000 people in each of the 2 communities. And what they showed here in terms of the primary endpoint, this is HIV incidence at the 2-year time point, was estimated to be 0.19 per 100 person years in the control arm and 0.06 in the intervention arm, so 60% reduction in HIV incidence in the intervention communities. And that was in real terms at 22 recent infections in the control arm and 7 in the intervention arm. And what they showed is that difference was seen across all the pre-specified subgroups. And one of the secondary endpoint was just to look at the coverage of HIV prevention. So that's PEP and PrEP. And there was a 4-fold increase in coverage of PEP and PrEP from 0.41% to 1.6%, comparing the control and the intervention communities. And I found this really interesting because, this was still a low level of coverage of prevention services, so just under 2% of people. But nonetheless, you saw a very substantial reduction in incidence, which suggests that the prevention interventions were being well targeted by the scale up of this precision health intervention. So their summary and conclusions were that their intervention reduced HIV incidence by 70%. And it was sort of piggybacked on government infrastructure and products. Digital app was linking the clinic and the community was a key component. They argued that it was a scalable intervention, and the increased prevention coverage was likely the major driver. And it's a package of care that could include new products such as injectable PrEP when it becomes available. The last study that I want to elaborate on was another antiretroviral treatment study that was involved a novel regimen, 2-drug regimen of doravirine and islatravir, and I'll explain what they are compared to a triple drug regimen of bictegravir, FTC, and TAF. And they presented the week 48 results of this study. So the novel regimen that they were assessing as first-line antiretroviral therapy involved doravirine, which is a second-generation NNRTI in the same class as efavirenz, in combination with islatravir, which is a first-in-class drug which is a nucleoside reverse transcriptase translocation inhibitor, which has works at multiple steps in reverse transcriptase to inhibit them. And so essentially this involves a 2-drug regimen with both drugs targeted at the reverse transcriptase, which makes it quite a unique regimen. And previously this regimen has been used as a switch strategy, so taking patients who are virologically suppressed and switching them to doravirine and islatravir, showing that they maintain adequate viral suppression. But in this study presented at CROI, they looked at it among patients starting antiretroviral therapy, comparing the 2-drug regimen, doravirine and islatravir, to a 3-drug regimen, as I said, bictegravir, FTC, and TAF, to people who were naive to treatment. And so they enrolled people with a viral load of about 500 who were treatment naive. They had to have no evidence of active hepatitis B because the doravirine and islatravir have no anti-hepatitis B activity. And they randomized them to the 2-drug regimen or the standard 3-drug regimen. And the primary endpoint presented was at week 48. Importantly, many of these patients had high viral loads, with 10% having a viral load above 500,000 at baseline. So these were patients with significant viremia that were included in the study. And the headline finding was that if one looked at patients on doravirine and islatravir compared to those on the 3-drug regimen, the rates of virological suppression at 1 year were comparable at 91 and 90%, and that the doravirine and islatravir combination was non-inferior to the 3-drug regimen. There were 2 cases who developed resistance in the doravirine and islatravir arm and none in the 3-drug arm. So that was one difference. There were 3 new hepatitis B infections in the doravirine and islatravir arm as well. That was another important difference, but weight gain was similar, which is quite interesting because the drugs in the integrase inhibitor class, like bictegravir and dolutegravir, have been blamed for weight gain, but they didn't see any evidence here that there was any increased weight gain with bictegravir compared to the doravirine and islatravir arm. And this was also published at the time of the conference in Lancet HIV. Last slide that I want to present is just to say that there were a number of exciting presentations of really phase 1-2 studies looking at what is now termed ultra-long-acting injectable antiretroviral therapy. So these were studies that just looked either at the PK exposure, the pharmacokinetic exposure of these drugs, some early safety data, and some early efficacy data, ability to suppress the viral load over the short term of drugs that can be given 4 to 6 monthly. So the first abstract there was a integrase inhibitor that can be given intramuscularly 4 monthly. And the second one was a capsid inhibitor that can be given subcutaneously or intramuscularly every 6 months. The third one, an integrase inhibitor every 6 months, and the fourth one, a CD4 binding antibody that can be given subcutaneously every 4 months. I'm not going to go into detail about this, just to say that what they demonstrated across these studies was a range of findings that either the PK exposures were adequate, there was safety, and in some cases there was good virological suppression. And the development of these products continues. And the aim is to find combinations of very long-acting intramuscular or subcutaneous injections that can be given in combination and allow us to provide antiretroviral therapy with a 4 to 6 monthly injection. And that's really what the future holds once with the continued development of these drugs. So that's what I had to share, just highlighting some of the important abstracts presented at CROI, and happy to take any questions. Thanks very much for your attention. Hi, John. John, I'm not hearing you.
I couldn't unmute for a moment. I was controlled. Just a quick question, Graeme. So the two TB HIV trials that you presented early on, mortality around what, 20 or 25%. Did you look at cause specific mortality, or did you do like the verbal autopsy thing, and that other trial did?
The deterrent, yeah.
Yeah.
So both the trials have firstly to say many of the deaths occurred in hospital, either during the initial admission or during subsequent admission. So we have medical summaries of all of those, and we're just analyzing them at the moment. To say that, in our trial, the New Strat TB trial, the majority of deaths were attributed to advanced HIV and severe TB. But then in addition to that, about 20% were suspected bacterial infections. There was about 15% were acute kidney injury on top of that. And then a range of other opportunistic infections. So we have that data and we're analyzing at the moment. But the key driver appeared to be severe TB itself in the context of advanced HIV.
So you think they were adequately powered to show an effect on TB, on total mortality?
Yeah, I mean, I think that, a trial in the Datura's case of 900 participants, and, the DSMB made the decision to stop for futility. I think that was definitive. And in our trial, there was no difference, 700 participants, prednisone versus placebo. And as I said, I didn't present that data, but what we presented at CROI last year was no difference at the primary endpoint with the intensified TB treatment and higher mortality at 2 weeks with the intensified TB treatment. So, a signal of harm that we still have not defined what the cause of that was, because it was nothing obvious. It wasn't drug-induced liver injury in that case.
Great, thanks.
Elsa, you're back online.
Yes, I am. Thanks,
Yeah.
Graeme. Is there anyone else, any other questions? I don't see any more hands raised. So if there's anything, please feel free to reach out, email, reply to the email that we sent this morning, and we will pass this on to Prof Meintjes for responses. But in the sake of time, I just wanted to thank everyone for attending today. And thank you, Graeme, for your time and for this very informative webinar. I just wanted to add that our next webinar will be on the 28th of July, and it will be a presentation by Professor Isaias, who is one of the PIs on the Revive trial in Ethiopia, and it'll be on HIV and leishmaniasis co-infection. So we will be sharing that save the date soon, and then also the invitations shortly after. Thank you to everyone, and have a great day further.
Thanks, Elsa.